people sometimes do have to be switched from one ART regimen to another. So what are your triggers for doing that?
I mean, the perfect example would be someone who, I was contacted about his refills just recently, and he's taking old tenofovir, so the more nephrotoxic one, plus twice daily raltegravir. And, I could very easily say to him, look, you want to take 2 pills a day instead of 3 pills a day, and want to take a safer medication, and to him it all sounds great, and so we made the switch. He's virologically suppressed, he's never had trouble with this regimen. I offer him the opportunity to take something safer and easier to take, and he's happy to do it. That said, there will be some people who say, I don't want to switch if it's working. It's our responsibility as clinicians to identify those patients and switch them if they're taking something that we think is harmful to them. So,
So that's the convenience and subclinical tolerability.
Right, exactly.
Then there's the clinical tolerability issues where people are having side effects. That's another reason.
Okay.
And then virologic failure and
I was
drug-drug
going to say,
interactions.
I mean, clearly some of your patients are going to get resistant to some of this stuff, right? And that would be a trigger.
Yeah, I mean, I have a patient
rare.
on rilpivirine-based treatment right now. That's a medicine we haven't mentioned, and she's having terrible esophageal reflux. And so she needs to go onto a proton pump inhibitor. So
Right,
her
so
has
has
to
to
be
change,
changed.
sure.
That drug requires stomach acidity for absorption. So.
And I will say, and Eric just mentioned it, the number of people that actually fail with resistance. I mean, we have patients that we've treated since the 90s that have a lot of resistant virus kind of below the surface. But people who are started on therapy now, really they suppress or they don't take it very well. And for
not
whatever
taking
reason.
it very well is really not at all.
Right,
Or very little.
and you just don't see much resistance. I mean, if you look at the British Columbia data, we have some data that'll be at CROI. It's just not very common.
Yeah.
I want to say a couple of things about switching therapy. First, I think it's important for providers to know that if it ain't broke, don't fix it is not a good way to manage patients, okay? Because sometimes patients do have intolerances that could be improved upon. And I think to ignore those just because the viral load is undetectable is a mistake. And patients need to understand that if they switch off of what they're currently on, they can always go back, assuming that they don't have resistance issues
Right,
that
if
have
they're
developed
suppressed,
after the
if
switch.
they're suppressed, right.
That's one of the reasons why a lot of patients don't want to switch,
Right,
because
I agree with
they feel like this combination has saved their life, and they are so enamored with that combination that they just don't think that they can switch off.
But you've got to convince them that it's saving your life, we've got something better, and this older drug may be doing something that's shortening your life.
The question is, what kind of car do you want to drive? There are some old cars that'll get you where you're going, but now these days they have got cars. They have a fax machine in them, and you can put a USB port in there. You can play your own music. Wouldn't you rather drive an updated vehicle if you can?
We all have anecdotes of patients referred to us for a consultation for antiretroviral therapy. Can you simplify the regimen? And to use one example, I saw someone recently who was on 4 nucleosides, efavirenz and boosted darunavir.
Oh my God.
Right. That was the regimen that saved his life.
Right.
So that's the one he's still on. He's been on it for years. That is just too toxic.
What do you do with a patient who's got constant low-level viremia, 500, 200,000 copies? What do you do with that guy or that woman? Anybody got a brilliant idea?
No,
So it's probably one of the areas I think where you could say there's the most controversy, especially between that undetectable and maybe 200. And that we do have quite a few people, although I think less since we're using more integrase inhibitors, but we do have a subset of people that are just cooking along in that range. And the majority of them, it doesn't seem like when we switch therapy or add drugs, anything happens. So we don't help them. And the majority of them don't seem like they're failing. So I tend to just watch them closely, make sure that they're taking the meds consistently, make sure there are no drug-drug or drug-food interactions, and just sort of keep an eye on them. And most of them end up doing just fine.
Weirdly, some of them even have resistance. If you do the GeneAssure archive, they occasionally you'll get one that's like, oh, they have 184V.
Although we have undetectable people, we do the GeneAssure archive, and they have resistance.
No, exactly, but
I don't know what it means.
Yes, I don't know what it means either. They have resistance to some of the regimen they're taking.